Well, good morning, everyone, and welcome to the first Carsey Policy Hour of 2025 with Kirk Williamson of New Hampshire's Prescription Drug Affordability Board joining us today. We're really excited to hear from Kirk and to engage in a vibrant conversation afterwards. So please feel free to put your questions and comments in the chat as we go. Loyal listeners of the Carsey Policy Hour series know that last fall we polled you on what time works best for the series. The people have spoken, and the early risers and pre-workday professionals have it. We are continuing with 8 a.m. on the second Wednesday of each month, September through June. Recordings and slides are online at Carsey's website, including last month's fantastic session with Troy Moon and Henry Love on how municipalities can support energy efficiency measures in non-subsidized affordable multifamily housing. Check out that recording. In addition to our partners at the New Hampshire Municipal Association and the New England Municipal Sustainability Network, or NEMS Network, which co-sponsored last month's session, we want to give a shout out to our partners at New Hampshire's Bureau of Education and Training with its Certified Public Manager program that feeds into the Carsey School's master's programs. So today, prescription drug affordability. Such a simple and obvious concept and such a complicated labyrinth of different public and private sectors, motivation, layers of government. How do we reward market-driven research and development while protecting patients, employers, and taxpayers? New Hampshire is just one of just 7 states with a Prescription Drug Affordability Board tasked with tackling these questions. Kirk Williamson is the founding executive director of the PDAB, formerly working in healthcare philanthropy, a transplant from DC nearing his 1-year milestone with the Prescription Drug Affordability Board of New Hampshire. So Kirk will talk about a little bit about his background in healthcare philanthropy and how the broader system works before diving into the recent activity around the PDAB, the motivations, the accomplishments in this past year, and plans and opportunities looking forward. So again, please put your name and affiliation in the chat and get your questions and comments in the queue for the discussion following Kirk's presentation. Kirk, take it away.
Great. I'm going to go ahead and share my screen, and I would like for you to confirm that I am sharing the right screen. Thank you, UC. Like UC said, my name is Kirk Williamson. I am the Executive Director of the Prescription Drug Affordability Board here in New Hampshire. A little bit about my background. I started out in DC. I started at the National Governors Association. It's a bipartisan organization of all 50 states. Actually including all territories as well. We worked on a bipartisan basis, and that's where I started out working on state health policy issues, really around access to HCV, hepatitis C, viral therapies. At the time, that was really hitting state budgets, and states were scrambling for solutions. And that was in 2017, 2018. And that really sparked my interest in public sector policy, prescription drug affordability. From there, I went and worked on the COVID response with governors. And then I most recently was working in healthcare philanthropy with an organization called Arnold Ventures, tackling some of the most pressing policy issues. I worked on our drug pricing portfolio, really spanning the gamut from advocacy all the way through research and education. And so that was a very rewarding experience. And then that, I think, prepared me well for the work we're doing here. So I'll go ahead and dive into today's topic, which is prescription drug affordability and the challenges and innovation in New Hampshire. And just for a quick agenda, I'll level set with everybody kind of on the issue of healthcare affordability writ large, then discuss a bit about the background of kind of the issue that we're facing with prescription drug affordability here in the United States. What is the current situation? Kind of what are some of the state efforts? How have states responded? How is New Hampshire responding? Importantly, kind of recent work from the Prescription Drug Affordability Board. So let's go to the next slide. So I think it's important to ground this conversation in the context of affordability of healthcare overall. As a country, we spend far more on healthcare than other comparable countries, and we get the least from that spending. Resources for healthcare, be they medical services or prescription drugs, They are not infinite, and our budget to pay for them is just simply not unlimited. And not only do we spend more per capita on healthcare per person, the amount we spend as a share of the economy is large and growing. This year in 2025, spending on healthcare as a share of GDP is expected to reach its highest figure yet at 17.9% of GDP. And by 2032, healthcare spending is estimated to consume about a fifth of the US economy. And so the growing share of spending on healthcare, it crowds out our ability to use revenues or resources to pay for other social services that society might need. Things like investments in infrastructure or education or affordable housing even. And so drilling down into prescription drugs, spending on retail prescription drugs has increased rapidly since the 1960s, really accelerating in the 1990s. And adjusted for inflation, retail prescription drug spending per capita in the US increased from $101 in 1960 to $1,147 in 2021. And so not only do we spend more on healthcare overall than any of the other OECD countries, we also pay a much higher price for the same services and same drugs in those other countries. So take, for example, the oral medication Harvoni. That's a drug used to treat chronic hepatitis C infection. The average list price is about 132% higher in the US than in Switzerland. Switzerland is a very expensive country, and 89% more than the UK. The blockbuster drug Humira is priced at 265% higher in the US on average than in Switzerland, and 423% higher than the UK. And simply put, higher prices have consequences. 2/3 of Americans take prescription drugs. 28% of that cohort reports difficulty affording their medications. And that share is even higher among those in a lower household income. And 1/3 of Americans don't take their medicines as prescribed simply due to cost. And this has a cascading effect of worsening health outcomes, leading to lower productivity and life expectancy, increases in medical debt, and thorny societal trade-offs that we all must make. And so the rise in prescription drug prices, it really squeezes on three things: governments, federal and state, businesses, and households. And to focus on states, I would say that you're probably going to hear a lot about new cell and gene therapies, especially this year in 2025. Those are largely target Medicaid populations, small rare disease, pediatric populations, and they have enormous implications for state budgets. States, if you may not know, states have a balanced budget requirement. New Hampshire balances their budget every 2 years. Right now, we're in a budget cycle. So if a drug were to be approved mid-year that cost multi-millions of dollars and hits the Medicaid budget, that offsets our budget. That requires us to move funds around. And so this may mean cutting other benefits, and it could also mean increasing eligibility thresholds. There are various ways of handling those costs, but they're very real trade-offs. The increased healthcare expenditures also increase premiums and outpace wages. Makes the healthcare benefit one of the costliest operational expenses for employers, and it threatens their ability to compete in the global workforce. And households are among the hardest hit. I would say particularly those with lower incomes or those that lack comprehensive coverage. In New Hampshire, family premiums and deductibles account for nearly 50% of average wages. And so everyday people are having to make very difficult trade-offs about, should I take my required medicines or should I pay for things like rent or food or electricity? And I took a look at, there's an organization called Patients for Affordable Drugs, and they collect patient stories across the United States. And here's a sampling of some that I found from New Hampshire. Take Yael from Middleton, Wakefield. She said, my husband and I both pay for good insurance, $943 a month out of pocket, and then $6,000 for copays and then high deductibles. And now some of my prescriptions are just not covered and carry monthly cost of $500 a month. Then we have Stevie from Croydon and Newport. I'm a single mom of 3 and a diabetic. I have other issues that are controlled by my prescriptions, but my diabetes is the highest cost for medicine. A 30-day supply for one insulin is $800, and my second insulin is $348. It is not conducive for me to apply for assistance every time I need medicine. I take 9 different medications. The total cost for them for a 30-day supply is $2,209. I bring in $1,400 a month. I am on disability and I am unable to find a job. Without my insulin, I would die, but what do I do? Get my meds or feed my kids. Get my meds or pay my rent. When I get assistance, it's not always completely helpful. And why should the town or state be responsible for my medications? Why do pharmaceutical companies charge such outrageous amounts? And you can hear kind of the rage, the concern, that kind of the injustice of it all, kind of really within that last quote. Having to make these really personal sacrifices for yourself, sacrifices for your kids to stay alive. And that's something that we're trying to tackle here in New Hampshire so that individuals don't have to make those choices day to day. And so how did we get here? How do we get to where we have a family living in New Hampshire that's having to make decisions about whether to feed their kids or keep themselves alive? And certainly there's way more that I can go into than just what's on the screen, but I'm just going to orient you into what I think are kind of the foundational elements to give you the context within which we are working. So back towards the end of the 1950s, there were some Senate hearings that dovetailed with the thalidomide crisis. Thalidomide is a drug that when used among pregnant women, it can lead to severe birth defects. And in 1959, there were about 17 births of deformed infants tied to thalidomide in the US. This was a global issue, but it really hit home here in the US. And you can kind of understand the shock and horror of senators, representatives when they found out that the FDA doesn't review, or at the time didn't review, drugs to see if they were effective. They only reviewed drugs to see if they were safe. So that's where you get the term snake oil. People were selling snake oil. So in the 1960s, we have the Kefauver amendments to the Food, Drug, and Cosmetic Act that gave the FDA power to require pharmaceutical companies to provide not only that their drugs are safe, but also effective before they could be sold in the US market. And that's where we get the modern day clinical trial system, the preclinical testing through phase 4 studies. And these requirements at the time applied equally to brand name and generic drugs. So during this era, it was very, very common for generic drug companies to experiment with brand name drugs before patents on those brand name drugs ever expired, in anticipation of going for FDA review. However, there was a court challenge at the time, and the court held on the side of the brand name companies under Roche versus Bowler that it was patent infringement for a generic drug company to perform tests on a patented product during the patent period when those tests may lead to FDA approval. So by the late 1970s, there were very few substitutable generics on the market. It was just simply not profitable for a generic company to do all of this clinical testing that a brand name company had already done and then offer a much lower price and have to jump through those same hurdles. So another data point, about 150 brand name drugs at the time lacked generic versions despite being off patent. And generics accounted for roughly 19% of all prescriptions. Today, generics make up about 90%. But back then, it was about 19%. So in the 1980s, pharmaceutical companies, they were very concerned that because of this added requirement at the FDA, they were not able to fully enjoy the patent protection that came with the approval of their drug, and they felt they were denied their reward. And so a lot of this time was spent at FDA getting their drug approved. And so at the same time, the pharmaceutical marketplace was dominated by expensive brand name drugs, despite their patent protection having lapsed. And I put the Orphan Drug Act up there to give you another piece of legislation that also encouraged pharmaceutical innovation at the time. They were also concerned, lawmakers were concerned that manufacturers would not make drugs for rare or small disease populations, thinking that, they would never be profitable. So they added extra exclusivities. And then we have the Hatch-Waxman Act of 1984. That came into force intending to reconcile these two issues. On one end, restoring the patent period for brand name drugs, so maintaining those adequate incentives for innovation, and then incentivizing generic competition to lower drug prices. And certainly there are several pieces of legislation that have impacted either the financing or delivery of prescription drugs. But from my perspective and the work that I've done, the underlying dynamics really stem from the deal that was struck under Hatch-Waxman. And so in many ways, these laws were a remarkable success, speeding generics to market and lowering prices. Lower prices mean greater medication adherence and lower costs, but these policy choices are not without their consequences. From the 90s to the mid 2010s, we saw enormous price increases on existing drugs. You can think back to Martin Shkreli, the pharma bro, increasing the price of an HIV drug by like 800% overnight. However, we see less of that type of dynamic today where pharmaceutical companies are hiking up prices on existing drugs overnight. We're now seeing exorbitant launch prices on new drugs. So in the US, drugs are priced at whatever the market will bear. And in fact, the market bears a substantial amount because it's a very inefficient market. And in many ways, it's a tale of two cities. Miraculous products that cure us or improve our quality of life. And many products like that are fairly priced in terms of providing value through improved quality of life and longer survival time. And Americans, in fact, do pay less than other countries for generic drugs. And so in some sense, our system works extremely well to provide many products that we need at prices we can afford. But there are a set of products that don't provide much value. In terms of a better quality of life or a longer survival time, and they have very high prices too. And if those products we spend money on and yet are not providing good value for our money from the perspective of a consumer paying out of pocket or insurers that are making the decisions to provide coverage for that or other products, it makes it extremely difficult to manage costs and determine what gets paid and to whom. So over time, the balance that was contemplated under Hatch-Waxman, it went a little bit out of whack. It turned out to be, EpiPens are not fairly priced. It turned out to be a boon to the brand name drug industry by providing additional market exclusivity extensions, which translated into billions of additional dollars in revenue. We now have things like high-priced generics. There's something called an authorized generic, when a brand name company allows a generic drug company to sell their product in advance of other generics, and they get royalties and kickbacks. Anyway, that could never have been contemplated at the time by lawmakers because there was never a pathway for generics to come to market. So now we have other market issues that still need to be addressed. We have anti-competitive behaviors by brand name pharmaceutical companies, things like pay for delay tactics, patent thickets, product hopping, or evergreening. We have secretive rebates that are negotiated. They're held as trade secrets, and they're held confidentially from clients, from patients, others. And then we have really high launch and list prices. Average launch prices for new drugs increased by 20% per year from 2008 to 2021. That's 11% per year when you take out rebates and other things like whether it was a biologic or a rare disease. And a biologic drug is derived from living organisms versus your small molecule pills like aspirin or Tylenol. These are like injectable drugs like insulin. And while there's no one silver bullet policy solution, and we may not all agree on what is the most appropriate way forward, but I think we can talk reasonably about all these three domains, and there are solutions on the table that I think warrant a discussion. And so it's worth remembering that the bedrock of our system to incentivize affordability is the same as any other market in the United States. Competition drives new products into the market and drives down prices. The main challenge in the current configuration is that there are several drugs that never face competition, and therefore competition as the engine of affordability and innovation doesn't have the ability to produce more affordable products for people or our insurers. So let's just take a look at patents. Patents were intended to incentivize innovation. They provide 20 years of protection against competition, but they have been manipulated by brand name manufacturers to become tools to block competition and increase profits. The chart I show you on the left-hand side of the screen was created by an organization called IMAC, the Institute for Medicine's Access and Knowledge. they research these types of patents and anti-competitive behaviors. And this is Humira. And so Humira, for example, has over 257 patent applications. They had 39 years of monopoly granted versus the 20 standard. And 90% of those patent applications were filed after the drug was approved. So these patents don't cover the active ingredient. They are just these small tweaks to maybe the formulation or how the drug is delivered or a new indication. And you can see that much of the revenue is generated during those extra years, when theoretically we should have generic competition driving down those prices. Instead, we have these patent thickets that are blocking generic competition and increasing the price and increasing the profitability of the drug. So I know this diagram on the right is like really unfair to show everybody at 8 a.m., but I want you all to focus just on the black arrows. And the black arrows are pretty unremarkable. And this is how a drug is delivered to a patient. So a doctor, they write the prescription, the patient takes that prescription, they pay some portion of the cost, they get the drug, and their insurer will reimburse whoever dispenses the drug. But behind the scenes, all of the green and blue colors, that's the supply and financing chain. And it's littered with trade secrets, middlemen, confidential rebates, and information asymmetry. And so all of this means that it's next to impossible to know exactly what a drug costs for a given patient. And so what is the result? The US spends about twice as more on prescription drugs than any other country. We pay on, and brand name drugs account for about 10% of prescriptions in the US, but about 90% of spending. And the inverse is true for generics. So we dispense about 90% of generics, but they only make up about 10% of spending. And so we now today in 2025 spend over $500 billion annually on prescription drugs alone in the United States. So that's the system in the context in which states exist and find themselves. And as I mentioned at the beginning of my discussion, starting around 2016, 2017, with the launch of HCV drugs, those disproportionately hit Medicaid and corrections budgets across the United States. These drugs were curative. They are curative. They are life-saving drugs, but they were priced so high that states were enacting strict eligibility criteria. There was several lawsuits arguing that patients should have access to these drugs, but they were $80,000 a course of treatment, which is very challenging, as I said, for a state when they're trying to balance their budget and they're making trade-offs of whether we treat this population or that at the prices that were given. And so states really began searching for policy solutions to address, the immediate challenge in front of them and think through how do we best address all the other drugs that are coming in the pipeline. And so New Hampshire became one of the first states to establish what is known as a prescription drug affordability board. These boards look a little bit different in each state, and I'll go into New Hampshire's in just a moment. The picture of the United States I have up here, there are about 10 states that have what is known as an affordability review. Not all of these are affordability boards. They have some sort of function of reviewing drugs and for their prices and affordability. But just know that there are more than just New Hampshire. And there are other areas and aspects, and New Hampshire does this. We have limits on consumer cost sharing. You can think of limits on insulin, the $35 cap, PBM licensing, oversight, and regulation. There's a new law going into effect this year that's increasing New Hampshire Insurance Department's oversight of rebates paid and used by PBMs. And several states, about half the states, have transparency initiatives. And so, at the core of what we're really trying to do, at least in New Hampshire, is trying to improve at least public sector buying practices. And so whether that's by assisting payers of health plans for public sector employees, so state employees like myself, or municipal employees, corrections departments, or Medicaid, we're trying to partner with these institutions to help them make sense of their purchasing, think through solutions of how to either lower the price or better set them up in negotiations, or think through other policies or strategies that could be helpful in working with other states that are tackling this as well. And so the theory behind this work is that if we're able to reduce drug costs, that would allow the benefits of all healthcare services to be spread more widely throughout society. And so the New Hampshire PTAB, enter the New Hampshire PTAB. I have our mission up on the screen. We have a 11-member board. We currently have 5 members on our board. They serve 5-year terms. We are an independent entity that is administratively attached to the Department of Health and Human Services. We are led by a chairman who is Gary Merchant, and myself, and I am the executive director. We also have a stakeholder advisory council. That is a 12-member advisory council. They serve terms of 3 years. We meet on an ad hoc basis. It's really to advise the board when they want other expertise or to pressure test some of their ideas. We're able to use them as a sounding board. They also have a chairman, and that is Tyler Brannon, and he was previously with the New Hampshire Insurance Department. So a little bit about what we have done as the board. Every year we issue an annual report, and I'm just going to hit the highlights of our 2024 annual report because I think it's an important tool to increase transparency of prescription drug spending and the drivers of those increases, whether it's the price of the drug, whether utilization is spiking, or maybe it's a mix of both. And we reviewed spending for 4 New Hampshire public employee health plans. So the University of New Hampshire, the Community College System of New Hampshire, the Health Trust, and the State Employee Health Benefit Plan. And we looked at three of these metrics. You all will have these slides, so I'm not going to go too deep into these. I'm just going to hit the highlights. So for the costliest drugs, they represented about 44% of spending. So 25 branded drugs made up 44%, about half of the spending in 2023 alone. And so spending on just the top 5 of those costliest drugs was $60.6 million. And 2.2% of spending could be attributed to the most utilized drugs, the drugs that we utilize a lot, which were generics. And that's a good thing. The ones that we really need to manage chronic conditions are largely affordable, but that is not where the problem in spending is coming from. And like many other states, we saw a dramatic increase in GLP-1s, also known as the anti-obesity medications, and they contributed to more than 1/3 of increased spending. And so I also want to touch on, before I close, the Inflation Reduction Act of 2022. The Inflation Reduction Act did many things. Did a lot to drug pricing, but I'm just going to hone in on 3 key things that the Inflation Reduction Act did. One is that it instituted an out-of-pocket cap for seniors under Medicare Part D. It allowed CMS, Medicare, for the first time to negotiate a subset of drugs. Those new prices are known as the maximum fair prices. And those are just for certain high-cost drugs that do not face competition. And then a third key policy is there are penalties on single-source drugs and biologics whose price rises faster than inflation. So if the price rises faster than inflation, then those companies need to pay a rebate to the federal government, and that helps offset how much patients will pay in coinsurance each month for their drugs. And so included in our report, we did our own spending analysis comparing the prices that we paid under those 4 plans to what we would have spent if those maximum fair prices had been applied to New Hampshire. And we found that in 2023, if we had referenced the maximum fair prices, not excluding Medicaid, we would have saved an estimated $6 million. And that's $6 million just on 10 drugs alone. And each year, the federal government will negotiate additional drugs. So I think that's going to be an instructive and important benchmark, I think, at least for our work, and I think for other employers, small businesses, to take a look at these drugs and to ask your PBM or to ask your consultants, are we getting close to that price? and how do we get either closer to that price? And so what are some of the implications? I think we face the same challenges that other states face. Certainly the increasing utilization among anti-obesity drugs, GLP-1s. These are incredibly effective drugs, but they are priced at somewhere at like a midpoint. I wouldn't say they're overly priced, but they're priced at such a high point that the utilization is really driving spending. Patent abuses, as I mentioned, several of the drugs that were the costliest to the state also have benefited from patent abuses and other market exclusivities that have kept generic drugs off the market and forced everyone to pay for those drugs. And spending is really being driven by single source brand name and high cost specialty drugs. And that's an issue all states will need to tackle. And so, the board remains focused on surfacing policy solutions to ensure that there is fair pricing and sustainable access to medicines. And so I'm happy to talk more about any of that. I know that was fast. I know that was a lot to talk about. Certainly there are a lot more issues. I'm happy to take it any direction. But thank you all for hearing me out this morning. And UC, I guess I'll turn it back to you. Stop sharing my screen as well.
Kirk, you did it in about 25 minutes. You went from the past and national all the way down to the current and future opportunities in New Hampshire. So that was really incredible. Thank you. And we're already seeing some comments and questions in the chat. My favorite so far is Don saying Kirk Williamson is probably the most consequential person in state government. At least among those
coming from the most consequential person in state government.
Energy and health, both so important.
Yeah.
But wow, at that market distortions graphic, that was just, what we see above the surface of the water in the black line, and just how striking and convoluted it is behind the scenes. Lots of questions. So can you comment on the possible use of more government-imposed price controls on drugs and what impact, both positive and negative, that would have? Smacking of free market beliefs, where do we go considering the pros and cons of that?
Right. That's an excellent question. And I guess I would reframe it a bit. Instead of price control, so instead of saying, we're going to fix this price and, instead of paying $100, we're only going to pay $2. I think there's room for negotiation or for coming to the table and having a more informed discussion around what does the clinical trial evidence say? What are we paying for similar drugs? What's the current standard of care? And what's the delta between what you're charging and what we're already paying for? And I think there's room to negotiate up front a much lower price. I do think that, Medicare negotiation, there is discussion over whether we could extend that to the commercial market at the federal level, or whether states need to do that on their own, or whether if they can. And I think it would bring price relief. And I do think that there is room. Certainly there's enough room to keep innovation going. But I would say that an uneven or unfair approach, I think would dampen innovation, or it would slow down maybe the engine of which we find drugs coming to the market through small molecule pills. We may see a faster trend to biologics, or we may see higher launch prices. But I do think that there needs to be some sort of centralized negotiation authority, especially for states, because we aren't benefiting from the Medicare negotiation. And even though that's much later in the life cycle of a drug, there are several years that we're spending exorbitantly more, and no one is ever questioning whether that is worth the value. So I hope that answers your question. That's a wonderful question to ask. And I think that is going to be a very interesting policy question to watch this year and next, going into the future. What is the impact of the IRA on drug development? And there many academics are looking at it, but I would encourage you all to follow it. I find it fascinating.
Right. And then another question connected to this might be, how about just not paying for brand name drugs? again, it's related to the engine of development, right? Of research and development, where those brand name drugs are put forward by companies that are
Right.
investing, perhaps with public subsidies, but can
Right.
we just move to generics as quickly as we can?
There are many laws. There are state substitution laws. So generic drugs can be automatically substituted at the pharmacy counter. Um, but again, brand name drugs, these are patented drugs. There's no other alternative. So you are in a hard place of denying access to patients who may need or may want that drug. And that is the challenge that insurers, that policymakers, that lawmakers in other countries that we all face. Do we slow walk coverage of this branded drug until they give us a better deal? Do we just say it's not worth the fight, that we'll pay for it? And I think, but there are policies to get generics to market faster, and maybe there are different business models for drug development that we should be thinking about and having discussions over. But I think we can't just not pay for branded drugs. Now, maybe some aren't worth the value, and maybe some should be excluded, and that would be a plan by plan decision. But I think largely we can't get away with not paying for the drugs. We have to pay some number. It's just, can we get a lower number at times?
Right. Quick comment to attendees. If you could keep all of the questions in the chat itself, I'm trying to blend questions and comments, so that would be helpful to have it in one place. Also, if you don't have your name connected to your login or your ID, just please drop your name in there too. That would be helpful. And Kirk, we have a question about contacting you directly. I put
Yep.
in the link of the PDAB, but may I drop in your personal address?
Absolutely.
Okay.
Absolutely. Yeah. Happy to be connected or answer questions offline.
Yeah, and so the importance of patents obviously is
Yeah.
is huge to to our market
Hmm.
economy.
Hmm.
Is there any chance we might see a policy approach to review patent extensions more rigorously?
Interesting. Um, so there were a few bills in the last Congress that almost made it over the finish line that didn't. Um, and and there were a package of bills that were coming out of the Judiciary Committee. One was looking at patent thickets. So that's when drug companies amass a large amount of patents on one drug. I had said earlier around Humira how they had filed for 257 patents. Each one needs to be shown to be invalid for a generic to come to market. That's what's known as a thicket. So a generic company has to cut through all of that. There was a bill that would have limited the amount of patents that a drug company could assert in court. So that would have greatly decreased the amount of time and resources that a generic company would need to expend to bring their drug to market, and it would more quickly bring generics to market. And there are some bills that are looking at pay for delay agreements that may look at product hopping. So when you tweak a drug right before your current drug is going off patent, and then you shift everybody to that new drug and you take that other drug off the market, that's called product hopping. And that new drug is the same as the old drug, except it's more expensive and now it's on patent. So it's much harder when you're getting into legislation and how do you actually tamp down on that behavior. And words matter and when you write legislation. And so there are policies on the table. I think there is a group of academics. I mentioned the Initiative for Medicines Access and Knowledge, IMAC. They do wonderful work. I encourage you to look them up. There's a wonderful think tank called R Street. Wayne Brow, he does wonderful academic work on patents and its role in drug development and drug pricing. And so I think, I'm watching those people, looking to them, seeing what they have for solutions to a lot of these issues. But patents and market exclusivities, those are some of the more formidable challenges to drug pricing and drug pricing reform in this country.
Thank you. Kirk, I'm going to bundle a couple of questions and throw them
Yeah,
at you. I know you can handle it. Questions about the administration changes coming up at the federal and
sure.
state level. So, what do we know about Governor Ayotte or President Trump's how they might approach these topics,
Yeah.
and including the legislature as well? And then drawing on your experience with the bipartisan approach of the National
Uh-huh.
Guards Association. Um, Given the perspectives of these executives and legislatures, what
Yeah.
might be some bipartisan approaches that we could take at, again, both the state and federal level?
Right. Excellent questions. And I don't have a crystal ball, and I have not talked to the governor, and I've not talked to President Trump. So I don't exactly know what they're, or President-elect Trump, um, may be thinking. But if past is prologue, um, the Trump administration did do several things around drug pricing. Not all of them got off the ground, but one of the bigger policies that they put forward were tying drug prices to international prices, and saying that we were going to get the lowest that other countries were paying. We may see that come back into the discussion. I don't. I think the last time I looked at their website, there was no mention of international reference pricing, but that doesn't mean that the administration wouldn't do that again. Um, and certainly that's an interesting policy to tie to other countries. And so there we could see that come back again. Um, I would think that at the state level, I don't believe Governor Ayotte has said much on the campaign trail around drug pricing, but this is a bipartisan issue. Drug pricing is something that affects all of our families. It affects everyone. I think all of us know either personally we've had this issue or someone has had an issue of going to the pharmacy, not being able to pick up a prescription, or going into medical debt, or coming out of a hospital and they paid $1,000 for Tylenol. The system is broken and it's not working across the aisle. It doesn't work for Democrats. It doesn't work for Republicans. And we may disagree sometimes on the solutions, which is why I put up kind of those three domains that how I look at the problem. There are three key issues, and we need the policy solutions under those to flow so that we can bring about change. And if we're working in a free market, there are still ways in which we can think about better negotiation power. But we need to be creative and flexible. And I think that both administrations, I think, have an appetite for change and for doing right by the people and for ensuring that families have more at the end of the day, so that the life that we're living is a bit more affordable. And I think that is something that can appeal across the aisle. I don't have a crystal ball, but our PDAB is enthusiastic about working with the incoming governor. And when it comes to the state legislature, we have many legislators actually on our board. So we do have a good relationship, I would say, with the general court. And I think our challenge sometimes may come from sustained funding, just like any other government agency or entity, needing funding to carry out the work, and to implement, because this takes a long time and a lot of work, a lot of buy-in, a lot of stakeholder buy-in. But it's just a lot of education. But I don't see this as being a major policy year. Again, this is a budget year. A lot of the decisions are going to be grounded in what are we paying for, what can we continue to pay for, where do we get the revenues from, and if a policy is tied to that, I think you might see it get included in this year's budget. But I think most of the policy making will probably be done next year, if I was to read the tea leaves of the general court.
That's helpful. The questions are coming in fast and furious. I'll try to get to as many as I can. And again, I encourage folks to follow up with you or to follow the work of the PDAB. Stepping back, this is such an intractable problem, one of the wicked problems that are grand challenges that people talk about. And I come back to the idea of incremental versus radical change. When Deb Fournier from the UNH Institute for Health Policy and Practice came in to talk about the Medicaid and in particular the
Yeah.
unwinding in New Hampshire, um, it was clear that in building the system, it was really just an add-on of
Mhm.
sort of the system grew not in an intentional way, but in the well-meaning decisions of a lot of people, putting together Frankenstein, perhaps.
Right.
And so, you know, you're working in an incremental way, but talk to me about whether it be better to burn it down. What is, how do we actually make deep
Yeah.
systemic change?
Yeah. Um, yeah. I mean, if I could be Cersei Lannister and blow it up, maybe I would. Um, I Yeah, I mean, you bring up an interesting point, and like I guess it is kind of the tension between like should the federal government just do it all, and or should states just do it all? And I mentioned at the beginning of my talk that I worked at the National Governors Association, and we believe, and I believe very strongly in state rights, and that states are laboratories of democracy, and I think states should be allowed to experiment. I think that we do need help from the federal government. It is incremental, it is slow. There are things we talked about patents for a while that would all be done at the federal level. There's really no lever for states to pull around patents or patent gaming. And so the solutions for us may look different than what they would be for the federal government, and it takes an appetite of willingness to push forward meaningful policy solutions that may seem radical, but they are incremental. And that's been an interesting dynamic to watch. And I think one thing you can think of, or one thing that it made me think of, UC, when you were posing the question, was the discussion around PBMs, pharmacy benefit managers, the middlemen, as they're called, that negotiate the rebates between manufacturers and pharmacies and insurers and dictate how much you'll pay. Um, there's a lot of discussion at the federal and state level about what do we do, and I think not many people have articulated well what the problem really is. They are our last line of defense. They are the only ones negotiating. So if we don't allow them to negotiate, then we don't have negotiation at all. So we need to be very careful when we do knee jerk assumptions. That's why policymaking is interesting. It's hard, but it takes a lot of understanding of how a market works to understand where your leverage points actually are. And certainly there are things we need to do around oversight and licensure and regulation of PBMs, but that just goes to show that sometimes our policies could be detrimental either to the industry as itself, which we don't want. We want our drugs, but we need to think about what is the right balance now. And I think it needs. We won't have radical change. I think radical moments lead to change, and I think that change is incremental. But I would look to other countries and say they have a centralized negotiation system where they really critically evaluate the evidence behind that drug, its net health benefit, whether or not the benefits outweigh the safety risks, and whether or not the price that's being charged is comparable or fair to what we're paying or should be paying. And because they do that on a systematic basis, and we don't, we may have an opportunity at the state level, we may have an opportunity at the PDAB to do that and to lower costs for patients, for the members of these plans, and lower costs to the state. And that's what we're focused
on. Fantastic. The idea of something that seems radical but is really incremental is an idea I'm going to chew on. I think we sometimes really focus on the change around the edges.
on. Mhm.
Uh, In any case, so, PDAB is focused on public employee health plans. And I
Yeah.
think just to be clear, this is a way to support our public sector employees and their families. As Don has mentioned, it's a
Mhm.
way to support taxpayers and those who would benefit from the other social services that have
Yeah.
been cut due to, the
Right.
prioritization and opportunity costs. And then your third point about the labs and models for others. Um, New Hampshire is one of 7 PDABs. Talk about PDAB activities in states that might be
Yeah.
further along in
Mhm.
implementation, and where you see New Hampshire, what does success look like in 1 or 5 years for the PDAB in New Hampshire?
Right. Yeah, so New Hampshire is one of 7 PDABs. Even though we were one of the first, we're not the furthest along. Unfortunately, I could say that, but there are other states like Colorado, Maryland, and Oregon. Those 3 states are probably the furthest along. Maryland and Colorado, in particular, are the furthest along. They have the authority to implement what is known as upper payment limits. So above which no payer or purchaser could pay more than. So they are looking at what they paid for, just like kind of what we did with our spending analysis. They prioritized a number of drugs. The board selected drugs. Now the board is reviewing those drugs to determine whether they're affordable or not. And then we'll decide whether to implement an upper payment limit after considering various factors such as R&D costs, manufacturing cost of therapeutic alternatives, et cetera. And they're much further along in that. And that's one approach to policy. There's one approach to this issue, by reviewing, selecting, and then implementing UPLs. In New Hampshire, we do not have upper payment limit authority. We simply make recommendations to agencies and to public employee plans. And notably in Colorado, it's across the entire market. So they're not just looking at state or local governments or public sector employees like we do. They're looking at the commercial market as well. So they have a much broader reach and a much broader cross section to look at than we do, and a much bigger impact, I would say. And so, it would be exciting if we ever got the authority also to look or to help those in commercial plans. But I think here in New Hampshire, we're figuring out what is the next step. In our legislation, it instructs us to define or to set spending targets for specific drugs that pose affordability challenges. And so this year, we're really going to be focused on determining, what is a baseline number for which above that number, these drugs would be unaffordable, and what is an appropriate number for these plans to pay, or for these plans to band together and to bulk purchase the drugs. Who knows? And I think the solutions vary by drug. But this year, our PDAB is very focused on developing some sort of process whereby we review these drugs, determine which ones are unaffordable, and try to help the decision makers to either get to a lower price or negotiate to a lower price. And some of this may just be awareness raising and, kind of shaming some of these companies, and maybe it pushes towards new solutions. But I think right now we're about seeing where we're at, empowering the people that can make the decisions, and seeing how far we can go.
Absolutely. And, this systematic review and analysis seems critical. We have a question about transparency. And
Yeah.
I wonder if these other PDABs are like not that the other PDABs, but clearly the PDABs in your analyses have some access to prescription drug prices. Your annual report is full of this price data. They're private databases, then one can access by, as our questioner asks, forking over huge sums of money.
Yes.
So,
Yes.
it's not like the information is truly secret. Why can't this data just be public? And are there places that have more rigorous data available to consumers than others?
Yeah, that's a great question. Um, the what is so secretive in this market are the rebates. Is the difference between the list price, what that pharmaceutical company charges, and then what that plan negotiates as 20% off, 30% off, 40%, whatever the discount is, off that list price to whatever that net price is. That varies by plan. A lot of these rebates are bundled by volume. It's incredibly hard to disentangle, and all of these rebates are secretive and confidential. And that's where those proprietary databases come in, because manufacturers do report to those proprietary databases. So we at the state, using the All Payer Claims database, we do not have rebate data. We only have cost data, so what the insurer paid. We don't know the net price, which is frustrating for this work for sure. And I think you can get information. We have the ability to get information from insurers and PBMs and manufacturers themselves. We have not done so yet. We do have that authority. But for those looking for more information around drug prices, drug pricing, I would say the Kaiser Family Foundation is a wealth of knowledge. The Commonwealth Fund, certainly. When you're looking at prices of drugs, there's a group called 46 Brooklyn, which is also from a group called Three Axis Advisors. They do a lot of work looking really at the unit level of what a drug is through Medicaid. So there's a lot of transparency through Medicaid. I know that the rebates there still are still very secretive, but there's a lot more public reporting from the federal government, and so they do a lot of the disentangling for you. But stay tuned for more of our work. We can't publish everything. We can't by law, but we will continue to put these reports out. Hope that they're a wealth of information. I know some of it may not seem immediately actionable, but hopefully it's something that you can use to understand, or to talk with your provider, or to talk with your legislator, or to come to the PDAV and talk to us yourselves about whether or not you think it's affordable.
Kirk, we are rounding the end of the hour. I've put together a couple of questions based on asking about the pharmaceutical and insurance companies' financial activity and any regulation surrounding those, in the income and balance sheets. So these three questions are: number one, what percentage of new drugs developed are initially funded by government funds and not companies, which puts the market equation around research and development
Right.
through a different lens. Are there concerns about lobbying or political contributions or PACs from large pharmaceutical companies? Any differences at state or federal level? And then finally, advertising. Two people asked about just the preponderance of advertising. Maybe advertising is half or even more of the costs of some of these. And can we limit that for the sake of the market overall? So, what's going on within the pharmaceutical companies that we can understand and maybe guide a bit more.
Right. And I know we only have like 2 more minutes, so I'll try to be quick with this. The first one about the government's role, yes. So nearly all new drugs that come to market are in some way funded by the federal government, whether that is through basic research, funded through the NIH, coming out of university labs. There are studies that have linked patents on new drugs to federal funding. I don't have the work in front of me. If the specific person wants to reach out, I can send you that paper. But nearly all new drugs coming to market in some way are tied to federal funding. Now, there are different models for how that works. But so that's the first question. The second question, what was your second question, you see?
Around
lobbying.
Lobbying.
Yes. Yes. There is lobbying, both at the federal and state level. In Congress, there are 3 lobbyists for every 1 member of Congress. And at the state level, it's not that burdensome, but there is activity from all corners of all stakeholders that are interested in this work. And so, yeah, lobbying is formidable. It's a lot of times you can find a lot of common ground with the industry, and you should talk to industry, have them either answer your questions or come to find solutions where there are solutions. And then the third what was the third question?
Around advertising.
Yes. Yeah. Advertising. We're the only country that allows direct to consumer advertising for pharmaceuticals. I think maybe us in New Zealand. And I think, yes, maybe we will see a rule change around that with the Trump administration. I think that was talked about in the last administration. It's challenging because I think advertising is free speech or deemed free speech in the United States, and that has a cascading effect for other industries. So a lot of thought would be needed to effectively target that. I think one issue that's really interesting to watch is direct to consumer advertising on TikTok, on new social media, using influencers to market products without ever disclosing that they were paid to advertise those products. You now have companies that will have brand influencers awards for influencers that do this, and you will never know that they were paid. to do a TikTok on it. So there's a group called Generation Patient, led by a woman named Sneha Dave. She's a young adult patient with Crohn's disease who is out there fighting this fight. She's galvanized a lot of university students into her work, and she's worked with a lot of folks in Congress. They even introduced a bill that would crack down on this practice. So I do think it's an issue to watch. You're right to point that out. It does increase demand a lot. And I think maybe we will see some action this Congress. Who knows?
Well, Kirk, thank you so much. It's
Yeah,
it's really been enlightening and an active conversation. We're excited to see how the PDAB moves forward and develops towards supporting health and economic prosperity for all here.
absolutely.
Thank you for your important work.
Absolutely. Yes. And thank you all. Thank you for joining me this early in the morning. Happy New Year. Take care.
I wanted to put just a plug out for our spring series. We have Carsey Policy Hour talks on independent journalism, on New Hampshire's demographic shifts, and for our annual Earth Day commemoration, energy policy 3 months into the new administration. The descriptions of those will be up in the next few days, but registration, you don't have to wait to block off on your calendar 8 to 9 in the morning on the second Wednesday of each month. So join us on February 12th for the next policy hour. Thank you, Kirk. Thank you, everyone. Be well.